Okay, we're joined by Professor Peter Hillman. Professor, a couple of things I'd like to ask you about. First off, can we talk about the measurement of minimal residual disease, MRD, post-treatment? Can you explain to us how it's measured in the lab, what it means for patients who fail to achieve MRD negative status while taking a novel therapy, for example?
So the depth of remission, or MRD, is an important predictor for how someone's going to do on treatments. And we know with certain treatments like chemotherapy or some of the new treatments, that if we can get rid of detectable disease, then those patients do better than the ones where we don't get rid of detectable disease. And we can measure that in the blood or in the bone marrow with very sensitive tests, which will pick up actually down to one CLL cell in 100,000 cells quite routinely now, using either flow cytometry or molecular tests, so tests in the lab. And if we're going to move towards cure, and that has to be our aim, then a prerequisite is to come off treatment, and therefore to do that we need to have no detectable disease. And so our aim is to try and get there with the novel targeted treatments. However, having said that, some of the therapies, you know, for example ibrutinib, if you control the disease will stay under control with detectable disease. So it's not always necessary to get rid of detectable MRD for all patients. For example, a patient who may have other problems with their health, who may just want the disease controlling and will stay under control for years, that's an appropriate approach as well.
Okay, your talk today, it was really encouraging in terms of the developments over the last 5 years.
Yeah.
Just tell us a little bit about those developments and maybe if possible get the crystal ball out and look ahead to the next 5 years. Will it be as exciting as the last 5?
Undoubtedly the last 5 years have shown a dramatic change in CLL, and it's based on our understanding of the disease. We really are starting to understand the nuts and bolts of how this disease started and progresses, and that allows us to develop treatments that will switch off specifically the disease. And that's had a dramatic effect for the outcome of patients, both in frontline and in relapsed patients at the moment. One of the big advantages we have is we have many different drugs being developed, so not just a single type, and that allows us to combine therapies. So we have trials that are recruited and recruiting now, where we're testing 2 or 3 drugs combined together, and I think that promises a really, especially when we use it in frontline, a really deep remission and potentially move towards curing CLL. So I suspect, and I'm an optimist, but I believe that CLL will be probably one of the first of the relatively common cancers or leukemias that we actually have a chance of curing without using a chemotherapy approach.
Brilliant. You're optimistic about the future?
Absolutely. I think we need to encourage support for the trials and for these new drugs, but looking at where we've come from in the last 5 years and where we're going in the next 5 years, there's no doubt we're making huge strides in CLL.
Professor Peter Hillman, thanks so much for talking to us.
Thanks.